So we will again take up Suven's presentation. He is talking on long and short eyes. So I think Ramesh's presentation was quite valuable. We are going for a new optical biometer, Ramesh, a new OCT machine actually. So it has an optical biometer upgrade. So I was considering how much I have to pay for the upgrade and compared to how much I have to spend for the ILMaster 700. And it is a huge difference. And most of the results have shown that, I mean, if you already have a macular OCT machine, all these things that you mentioned, that can be taken care of. You don't have to have those features in your biometer. Yes, Suven.
Okay, so thank you, Dr. Like I say always, it's when he gives me the topic, I curse him, and by the time I finish preparing for the topic, I'm a lot wiser, and I thank him for having chosen me for this. So, IOL power calculation in myopia and hypermetropia. I do not have a financial interest. I'm Suven Bhattacharjee. Now, the significance, I'm sure Dr. Ramesh has covered a lot, but there'll be a little repetition. So, Sir Harold Redley, we know, implanted the first IOL. It was minus 18 diopter spherical and minus 6 diopter cylinder that he landed up with. And later, Binkus introduced the 18 diopter pre-pupillary lens. Now, the patient was left with the same refractive error as he started with before the cataract surgery. So, merely an implant is not sufficient. We need to get it bang on. The accurate IOL power is necessary. And now, these are very wise words from Ken Hoffer. One group of ophthalmologists reads about the latest developments, stays up to date, and goes to meetings. That's you. And the other group feels more comfortable with what they have always used. Of course, they are not monitoring the outcomes. So, not much to talk about. It's absolutely decided that except where optical biometry cannot be done, the ultrasound biometry works well, but otherwise optical biometry is the first choice. Now, there are 9 types of eyes based on the size of the anterior segment and the axial length. There could be 9 permutation combination, and only about 73.4% fall in that median group. So that's where you get that point, the accuracy within 0.5 diopters. I think Dr. Ramesh has spoken about this. There are formulae over here which have evolved over the years. The first gen, which was in early 80s, and the second gen, where it was just a modification with a fudge factor, and the third generation, which were basically based on theoretical principles where geometric and optical characteristics were taken into account, where corneal power and axial length actually came into the picture. And then we had the fourth gen formulation, which actually held a strong position for a long time, the Holiday 2, the Barrett, and Olsen, and the Hygie's, where various factors like axial length, corneal power, white to white, and AC depth, lens thickness, and patient edge, and sometimes the patient's gender also was taken. Now, the newer 5th generation ones are where AI is used, and there you have a whole list, and these are still evolving. And like Dr. Ramesh already just said, Kane is one of the best, and Pearl DG is probably almost comparable. Now, there was this time in 2011 when Wang and Koch published this optimization of the powers, the calculated IOL power. The reason was for long eyes, the current formula that were there then tend to select IOLs with insufficient power, leaving the patient a little hyperopic. So they proposed an optimization. There were actually one center and a 2-center. This is the final 2-center reading, where a small addition of optimization was done to the existing formula, where you actually could make modifications. Now, the problem is these are all what is called static formulae. The AI formulae are dynamic formulae. So in a static formula, when you do an optimization, you're just moving the entire curve upwards or downwards. So you really do not come to the desired horizontal normal. Now, when AI-based optimization is done, the formula changes. The prediction errors are minimized as the original starting formula is transformed into an updated formula, which becomes more uniform and stays within the range of the 0.5 diopter which you desire. So these are the generation of formula. Like you'll see, if it's a normal eye, pretty much most formulae will work. But if they're long eyes, then you have these Holiday 2, Olsen's, Barrett, and Hill RBF. Short eyes is a big question. We'll come to that later. So this is a wonderful paper published by Mellis et al. In 2018, where accuracy of intraocular lens calculation formulae was tested. And if you see this curve, may look a little busy over here, but look at the Barrett, which is there in purple, and actually the Wang-Koch optimization has been applied. So the continuous lines are the ones where the original formula was used, and the dashed lines are where the Wang-Koch modification was used. And if you see the green one over here, that's Hoffer Q, is way off the charts. But with the Barrett, it's reasonable, and when the optimization was applied, it's come closer to the 0.5 diopter zone. Okay, so this is with the intraocular lens plotting prediction error, and when we do the axial length, again we have similar pictures. So the Hancock modification did help, but still we were off the mark reasonably. Now, in short eyes, the concerns that we have are there's a small axial length combined with a high power IOL that we're using. So the margin of forgiveness is very little. So we will have large refractive surprises with a minimal shift in the ELP. And another big factor you must consider is tolerance of IOLs. Now, the manufacturer gives you the ISO standards give you a tolerance range. Say 0 to 15 diopters, the range is 0.3 diopters you can err on either side. Let's see, if you're choosing a 10, it could be a 9.7 or a 10.3. But 15 diopters to 30, it's, I think, 0.5. And above 30, it's 1. So if you've chosen a lens of 31 diopters, it could be either 30 or 32. You don't know what the manufacturer has made. So you could be really off. So the margin of forgiveness is very little. Now, these are two meta-analyses, both published in 2022 on short eyes. Fairly large studies. One was in the Indian Journal, and the other is in the International Ophthalmology. Now, the Indian Journal one by Srivastava and co-workers suggested the Barrett 2 did pretty well, Holiday 1 and Hill RBF did pretty well, but none of the formulae was found to be statistically superior over the others. Very soon after that, the same year, this was published. The other in International Ophthalmology was published. The new generation formula based on AI and ray tracing, where Pearl DGS and Oculix were found to be very useful. In long eyes, the concerns that we have are incorrect axial length measurements because of poor eye fixation and posterior cephaloma. Now, if you see there's a long range of eyeballs, and there's increased risk of prediction error because of the axial length. Now, if it changes, it's about 26 millimeter. 1 millimeter increase in axial length will lead to an absolute error of about 0.1 diopters. But if the axial length is more than 33, it's a 1.1 diopters. That's a huge difference. And these are the incidence of posterior cephaloma, which is very significant, 30.5 and more. It's almost 35% of eyes have cephaloma. Now, when we look at the optical biometry concerns, the problem is that optical biometry assigns a global index of refraction. So greater the amount of vitreous, the more is the index of refraction contributes to the overall measurement. And that's where the error happens. And optical biometry will always overstate the axial length. Longer the eye, greater the error. But also, we must keep in mind that myopia is not always axial. So in ROP, it's mostly lens-derived, so it's a curvature, but it's high myopia is lenticular. Stickler syndrome, it's axial, whereas in Marfan's, it's both. Now, in long eyes, there are two meta-analyses. One is in 2018 and 122. In the 2018 one, for those times, it was good. It said that Barrett University was statistically, the errors in Barrett University were statistically much lower. So, so that was the recommended. But in 22, when we have, the AI-based newer generation formulae and Barrett 2 were considered to be better. So in summary, the accuracy of the refractive power of intraocular lens depends on the exactness of the IOL power calculation. Accuracy of the IOL power formula in turn depends upon the axial length and the corneal curvature. As of now, still there is no consensus in the literature. It is a constantly evolving field. A review of literature will always help us since it's dynamically changing. The Barrett 2 is best among the Vergence formulae, and Kane and Pearl DGS are the best among the AI as reported presently. Thank you very much for this opportunity.
Thank you so much, Suven, for covering a large topic in a